All right. Well, thank you guys and welcome to our second to last evaluation forum. Um, as I had mentioned before we started this recording, these are very informal, really meant to allow people to connect, to share resources for evaluation, to talk about where they are in terms of if you've started implementing these guidelines, and then what's available to help you measure the impact of them. So I just would ask quickly if you guys could drop your name and your organization into the chat box. That would be very helpful for us later on to connect anybody who needs to be connected. So a quick review of the Bree guidelines. We our primary audience is the HCA, but these guidelines really trickle down into the rest of the healthcare ecosystem in different sorts of ways, either through HCA contracts or by individual organizations picking them up themselves and doing this work. And these forums are to help either way that you've accessed the guidelines, whether it's in a contract and you want to be consistent, you want to implement something for that HCA contract, or if you want to pick these up yourself. We often have organizations that aren't, really part of that HCA pipeline who also implement our guidelines. So I wanted to talk just briefly about the tools that we have available to help with evaluation. We kind of have three big buckets. We have general tools. It's like our evaluation tool depot, and I will show you that online. Has resources for those kinds of organizations that are don't really have a lot of folks around who do evaluation, or they are implementing their guidelines in a department that doesn't really have a lot of evaluation resources. So it's things like there's a free EPI tab data program, and there's examples of logic models and kind of all the things that you would need to help you get started planning an evaluation on any sort of project that you're doing. And then we have this another section, it's collaborative tools. So these are tools that I really wanted to focus on today. These are like survey banks. They're modeled off the CDC survey bank. So we have both places where you can just drop in single questions that you have developed, or you can, if you're looking for some questions that you want to use in a survey, you can pull it from there. We've had one organization already who had implemented our asthma guidelines, and they created a survey for nurses, and then they have shared that out across in our survey bank, so that any school, this is for school nurses, so that any school who would also like to implement doesn't have to start over, create the wheel. They can just pull that survey and either use it in full or adapt it to their own needs. And then we have these report specific tools. So for these ones in particular, and Teresa, I know you were involved in this, we have developed a framework, like a theory of change, and this kind of narrative framework to help guide people through developing questions and thinking about their role in the kind of the ecosystem of how these guidelines, where these guidelines will be implemented. We'll share, and I will also share those in just a minute. And so, as I said, this is really meant to be just this very open space. I want to invite you guys to talk about, like, what are your priorities? Is this something that you're currently working on? Where are you working on it? Who are you working with? are there other partners that you've identified that can contribute to your success that you may not be able to engage with yet? And can we help with that? And then how are you thinking about measuring the impact of what you're doing? So I will stop there and invite you guys to come off camera, and we can chat about these collaborative tools, um, or your priorities. I think priorities is probably a great place to start in talking. Let me just stop sharing my screen here so you can see me as well. Sorry, just a minute. There we go. Okay. Hi, Ron. I'm really glad I saw Health Point was registered, and I'm really glad that you guys registered. Um, so Sharissa, would you like to start and just talk about kind of what the HCA priorities are around? Do you have any for evaluation or for implementation? How are you guys starting on this work?
So I think, for us, it's less about starting on the work and our capacity for evaluation beyond using what we already have in claims and encounter data is limited. But what we can do is look at who's being prescribed medications for opiate use disorder, who's prescribing them, and how long they're on them. And I think for us, the most meaningful way in which we have been, and probably for now, given all the constraints we're under, would continue to monitor is, can more folks, can we get more folks to prescribe MOUD? We know that we've got work in hospital emergency departments where people go in with a non-fatal overdose and they don't leave with MOUD. We know that people aren't sent home from hospitals. We know that nursing homes don't accept folks who are on methadone. Buprenorphine's better, but we still have nursing homes that won't take people with methadone. So I think for us, it's really, can we continue to increase the prescribing of medication? And then once folks are prescribed the medication, look to see how we can help support people staying on it. So I think for us, those are the tools we have and we've looked at, and really, how do we? That's our look right now.
Yeah. So prescribing MOD is really your top priority then.
It's because we can see it, right? We can look at that. And we can look at how long folks are on it. We don't really have a lot of tools when we talk regularly with our plans, but beyond that, we have no money to pay people. I mean, we don't have any levers right now. We can look and provide feedback and offer suggestions, but we don't really have any carrots, certainly, and sticks don't make sense when everybody's underwater and just trying to do the best they can.
Yeah. Drew, how about you? What are the priorities for your organization right now around MOUD?
We've done a number of sessions with our purchase, and again, we tend to focus on the commercial market. So we don't manage Medicaid per se, although we have, lots of our members who are Medicaid focused. And we've talked to the purchaser side of that, and from the purchaser standpoint, they feel like they have benefits in place, they've reduced their barriers, etc. They don't feel that they feel like they've opened up other doors in terms of access to virtual telemedicine type care, etc. But from a specific targeted approach to this, we were told to look at other areas because folks were already working on this, so we're using our resources elsewhere. Are we supportive of it? Absolutely. And I think, like Dr. Fantino said, it's the getting more people to prescribe is always, the issue. And when you look at the guidelines, it's, it's about screening. If you don't screen, you're not going to know. And once you screen and you get a diagnosis, and what are you going to do? You should do something, and on and on. So I think for us, that's consistent with our approach to a number of areas where we think that um, just screening appropriately will help get a more accurate diagnosis, and that will help you target your treatments. Because if you don't know, you're not gonna. I mean, this is one that providers can be oblivious to if they don't. If they don't look, if they don't have a system that helps steer members to them, i.e. the folks that hit an ER with an overdose and don't get follow-up. I mean, those are all big issues for us.
Yeah. It sounds like you don't have any sort of plan right now to implement any sort of intervention or any sort of.
Yeah, our quality improvement team has not taken this one up. When we looked at board initiatives, it was the board did not want to look at another opioid initiative. They had done numbers of those, and it wasn't popping up as a.
Yeah, so maybe one of the things that we can talk about is just how the Alliance might support spreading the Bree tools for evaluation, for example.
Yeah, absolutely. I think things like shared presentations, webinars, etc. is a great way to do that. We can host, we could either link to your site or link to a HCA site or some combination thereof, where we can put information pretty clearly, make it available for folks. We do a number of sort of joint webinars today. Even those aren't targeted initiatives for us. Like, we're doing one on vaccine misinformation next month, or October 1st, so 2 months from now, whatever. But that's with the health department. So but that's nothing targeted for us. So
okay, right. And Maureen, how about you? What does kind of implementation and evaluation of this work look like in your organization?
Yeah, thank you. Sorry for being late. I was at another HCA meeting with some nurse care managers for some of the work with MOUD. So I work with the CEDAR team at the UW ADAI. And so I can speak to the projects that I'm focused on. So I work with the state opioid response grant and a technical assistance and implementation role. So supporting sites around the state that are many of them have been doing this work for a long time, and have either nurse care managers or other care navigators, peers in a role that is helping to expand access to MOUD for folks in mostly clinical settings. So the work with SOAR is often, evaluation of SOAR work is often looking at, how many people have been started on medication. We hope to understand how many people are, kind of maintained. And that's a big piece of it, is getting people engaged, continuing to engage people in care. And another project that I'm on is a little bit different, with not so much engagement and more just getting people started, is with the Scala Northwest, another HCA project, really focusing on mostly the emergency department, but expanding in a little bit of different direction at times with the inpatient side, or inpatient, like hospital inpatient side of getting people started on buprenorphine, not substance use disorder treatment settings. And also some partnerships with EMS teams around the state. So helping to develop protocols to make it easier for people to be doing this work. The protocols are largely designed to be meant to be used in the emergency department, but have been adapted and can be adapted and Scala is working to adapt them for the outpatient setting, but I think outpatient settings are using some of those things. Really to lower the barriers and to make it feel easier for prescribers who may be on the fence about doing this work, right? They want to do it, but they're not quite sure how. So been involved in that, and a lot of the focus of that is giving people prescriptions. It's not looking at how, connections to care so much, although Scala does have a good way of giving people the option to connect to care. They work with the recovery helpline to establish people in settings or get people connected to telehealth appointments, but it's not really looking at that beyond that in terms of evaluation.
Mhm.
I'm trying to think. Oh, and the other project that I'm working to support also, HCA SOAR funded, is the Youth Buprenorphine Access Project, which is an extension of SOAR and helping to improve a capacity of it's currently the University of Washington's telebup line. It's going to be the state of Washington's telebup line starting in January, where people can call in 24/7, or well, not 24/7. The phone is answered 24/7. Prescribers are available, I think, from the morning to about 9 o'clock at night to get started on buprenorphine, and we're sort of helping with the adolescent piece of that. And an extension of that is trying to increase prescribing in the community, because people can get started by the bup line, but they need to establish care in the communities. And currently the bup line serves technically people in King County, and access to care is okay in King County for adolescents, but in other parts of the state, it's not as widely available. So part of our work is providing technical support, trying to figure out how to identify providers to mentor to get up to speed and not make that care available.
Do you know, Maureen, to that
Yeah.
point, are the telebup lines treating adolescents like Boulder and the other ones?
Yeah, so currently the hotline will refer youth, they can refer to Boulder Care,
Okay.
and Ideal Options would be the other, sort of like if there's limitations to where they can send people, those are the two that they use.
Okay.
Yeah.
But still not adequate yet.
Right. Yeah. I mean, ideally for
Yeah.
youth, you have more support. And telehealth is great for people who want it, but
Not for everyone.
Yeah, and Ron, I wanted to invite you to talk a little bit about HealthPoint if you've gotten over your technical issues, hopefully. Oh, I see you. Let me see. This might be. Ron, are you able to hear me? Okay.
Oh,
Sounds like you're still having some feedback. I see you on here twice. So I'll give you just a minute, Amran, if you still want to work out your technical issues. So my question to you guys is what would be most useful? The Bree is really interested in getting information about how people have implemented our guidelines. And we have found that people, will do it a bunch of different ways, and they'll evaluate it a bunch of different ways. We would really like to get kind of similar information from many different organizations, which is a real challenge. So I'm wondering if there are things that could help you. One, share the information that you are already collecting for, and Maureen, it sounds like you guys are already doing some robust evaluations on different projects. What would be a good way for us to connect with you and get that information shared? And Sharissa and Drew, kind of the same ideas. Are there things that we could do it, Bree, that would be helpful to you to be able to share this all in one place. We'd really like to, be able to report to the legislature. All of these partners did these things, and this was the results based on, some of the implementation of these guidelines.
I think, for the healthcare authority, we have so many measures that we're required to submit to so many folks, federal agencies, others, that frankly, there may be folks in the agency that look to see how. I'd have to check with our team to see how they monitor, the Bree guidance and implementation. So there may be more than I'm aware of, because there are folks who deal more directly with the Bree broadly than I do, just for a one-off panel. So I can ask if there's anything formal that happens. I think from a repository, I do think that it could potentially be helpful that this is not that if there is a place that shows this is everyone's problem, this is everyone's issue, everyone is working on this, or it's not everyone's problem, but it's recognized as a significant driver of ill health, and I mean that broadly, clinically, mentally, socially, community-wide, that if there's a way that can reflect, this is about commercial payers. We're not focused on it, but we've had conversations and they are broadening their coverage. This is about people on Medicaid. This is about families. What's the work that DCYF is doing? Department of Corrections, they're spending tens of millions, if not more, on providing care to folks with opiate use disorder in their carceral facilities, and have a high risk of death when they leave and they're not engaged or, started on meds and then have appropriate follow-up, they overdose and they die. So this is a broad problem. And if there would be a way to highlight all the different ways in which it's being addressed, that could bring different attention to it. Healthcare Authority, we have dozens of projects that are working on this. I know Department of Health has dozens of projects, the State Opiate Response Plan. So I think, is there a way in which to sort of say, this is the state's problem, and every agency, and I think we're gathering that across our state agencies. I think we are developing a list of all the activities related to the opioid epidemic. And now you can just throw in stimulant as well, because it's kind of both right now.
Yeah.
So, and I think, so I think, is there a place in which all of that can be displayed that could be helpful?
Yeah. So just a list of every project that's going on that we can find in Washington.
Maybe. I mean, I don't know. I'm just talking, but
Yeah.
again, I think people who do this work all day, every day, it's their passion, it's their commitment, and they see the devastation and they want to help. But if you're not in it, you're like, oh, that's somebody else's problem. That's just their work. This is everybody's work, and everybody's trying to manage this, but I don't know that we have the time or space to really share what we're doing, and that folks don't see that broad picture.
Yeah, that's a real challenge. So I do think that is one place where the Bree could be supportive. If the HCA is already collecting that information, at least at state agencies, I could start an initiative, maybe have a discussion with Maureen and have a discussion with you, Drew, individually, and start compiling a list of all of the places that are doing this work. And put it on our website and maybe even share it in a webinar and talk about what kind of the state of care looks like. Is that kind of the idea that you had in mind?
Yeah, I don't know that I have a well-formulated idea, and I don't, and I don't know who. Yeah, go ahead, Drew. I heard you.
No, I was just laughing at you because I don't think I have a formulated idea either. I should go on video. Sorry. I'm not very video worthy today. Yeah, I think trying to pull it together might be helpful, Carrie, because yeah, there's a lot of stuff going on. I think that's why our board said, don't spend our resources on
Yeah.
this, because there's so much going on elsewhere that we don't need to address it. Although, when you look at data and you look at findings and things like that, I mean, we have some very interesting ones, which, like when we looked at health waste, and one of the measures of health waste is prescriptions for opioids for low back pain, for first diagnosis low back pain, and you're more likely to get an opioid if you live in a more deprived neighborhood.
Yeah.
Right. I mean, it's just significantly more than if you live in a privileged neighborhood. And so we divided the state into the 10 deciles using the area deprivation index, which is a HRSA construct, but it's at the census tract level. And that's what we found, And so what's going on there? Do we have the bandwidth to go address it? No, and I don't think HCA has that, given the current resource constraints, but that'd be a really interesting research topic for a public health department in a medical school, UW, Wazoo, one of those, because that's pretty interesting stuff. We have not been able to engage the public health school at the U. They tend to want to focus on national type issues rather than local, but might be interesting.
That may change. That may change.
Yeah. Drew, I have a question for you. So this is actually something that I've been thinking about, is just reaching out to different universities and starting to engage graduate students to work on Bree topics, and having the Bree host them as
like
part, like a capstone project or something like
we
that.
Need help.
Yeah,
we need help.
We've had interns a couple of times. Could we get one from the UW? No. So who did we get one from? Baylor University. Right, because we couldn't get anyone at the UW. So, but you're right, because there are things that they want to work on, and I know when I did my MHA program, we had to do a big capstone project, and 25 years ago or whatever it was. Shows just how old I am. And so they always are working on something, especially the ones in the straight, MHA program, who are in their early 20s. They don't have those connections. They need connections. It, gives them some credibility, or at least a nice reference letter when they graduate. Something. I think the university should be really actively, pushing their folks out to, community organizations, and I don't see that they do that. But it's a great opportunity, especially to solve some of the tough issues that we have to deal with.
Yeah, I think if we had a directed idea about what we wanted to offer them to do a capstone project, it would be much easier for us. So I'm noting that down as maybe one action item, another action item.
About, the whole list of questions, could be a screening, why people don't get screened, why people get treated and other people don't, who are, looking at some data, because the data is available for research. I believe the HCA's data is available for research. We can't use it, but
pay for
that's one of my questions.
We do have research collaboratives we're building, but
yeah.
Sharisa, I wanted to give Amran a chance if he's got his stuff taken care of, and I also wanted to recognize Ryan here, who's joined us, and see if Ryan wanted to chime in.
Can you all? Am I echoing still?
No, we can hear you now.
Okay, perfect. And let me see if I can just leave this one out. How about right now? Can you all hear me?
Yes.
Wow, technology. It's and I really got a new computer thinking it's going to be much better. Hi, good afternoon. My name is Amran. I am the program manager for addiction medicine in at Health Point. And sort of we are low barrier access, and what that means is that we have urgent care and 10 or 9 other clinics around King County area. So there's 2 of them up in North Redmond and Bothell, and the other ones are in South King County. And so we have walk-ins, and our walk-ins, the way that it works is you can walk in 3 out of the 10 clinics. You can walk in every day in different times. One of our clinic is very unique in Auburn. It's called the Whole Care Clinic. I mean the Whole Care Program, and it's pretty much 8:30 to 4:30 is walk in at any time, and there is a team that is able to, if it's needs primary care, behavioral health need, we also have a peer in our team. In the other clinics, it's pretty much like, regular, we see addiction medicine as part of primary care, and what that looks like is the team is MA, a behavioral health consultant or a nurse, and then a provider, right? And so we don't turn anyone back as they come, but as you guys know, the capacities sometimes might be hard. There might be some of a wait time, but during the walk-in hours for those clinic, like it's just like an appointment, right? Once the patient walks in, they're able to be on the books, and just, it takes about less than 25 minutes per appointment, right? And so one of the things we offer, from Brixadi shots to Sublocade to Suboxone, and so we offer variety, right? And one of the things that we look at is retention is important to us, although we are working on, I think some of the clinics are better at that than others. But we're working on how to continue to retain the patients that access us, right? The other piece that we're really working on is like how fast we can get people on medication. So it's the same day medication. We have pharmacy part of our clinics. All of our clinics except for one clinic has internal, like in-house pharmacy, which makes it easier, quickly access. We also insurance is not a barrier. One of the things that we do is we help them navigate insurance as well. And so I actually came into this meeting to sort of learn more about how our other individuals, do an evaluation. I'm pretty new to Health Point, but it's been such an interesting and really great. I think we are moving along, and we, as any organization, we could always do things better, right? And so kind of learning from others as well, and how they're doing, and for us is patient experience is also equally important, and a lot of our referrals, especially whole care, is friends of mouth, right? Because I'm uploading some of the data pieces, and I'm seeing in friends of mouth, so if one patient has a really good experience, the other patient will have. So that is one of the things that we really work on, is experience in environments as well. Having a lot of the times is training our front desk individuals, how to do trauma informed care, what are how do you approach, because not everyone worked with our the population that we work with. So it's like kind of giving them those training pieces and just, you know, continuously knowing also what's not going well and how we can do better. I'm not sure if I'm answering all your questions, but
Yeah.
yeah.
Yeah, so it sounds like to me like you are really the kind of organization that could benefit from the types of tools that we already have available.
Mhm.
And maybe a piece that would be helpful is this more support around evaluation. Does that sound right?
Yeah, I think
Like more
so.
alignment?
Yeah, I definitely think so. I think so what's interesting is a lot of our clinics are unique as they are kind of like a standalone, right? And so every clinic might be different, and so sometimes it's hard to do standardization, but there's a lot of pieces like we can standardize, but like I think we also give clinic leadership opportunity to kind of work out what works for them, right? And an example would be sometimes like changing the walk-in hours because they realize that the numbers are low and individuals come in the afternoon, or the like kind of like understanding your community and the population that you're serving and kind of matching, aligning with that in terms of access. So
Okay. Yeah, that gives me some thoughts. And so I wanted to give Ryan a chance to chime in and chat about their work and where they are in terms of the ecosystem and what you're working on. And then maybe we could leave for about 5 minutes at the end and go over, you know, some ideas and then so that I can follow up with you all. But Ryan, go ahead.
So my name is Ryan Leininger. I work at Valley Medical Center, so more on the healthcare side of things. I am a manager on a quality team, and I've been working with our organization and doing a number of things related to opioid use disorder over the number of years, and we've had different iterations of things. I think most recently we've been revising the way that we're managing some of the care in our emergency department. So the patients that come in, I think historically we had more of a Suboxone, buprenorphine type induction that we would do. And we had done some of that through some grant funding and things over a number of years. We're looking at a couple different pathways of different types of buprenorphine inductions versus the methadone induction, ways to do that. We have a team of social workers that will typically meet with the patients when they're there in the emergency department. Some of those patients do get admitted if they need some more inpatient level care. Some of them then will get discharged. We also have this OUD navigator that's usually there limited time, usually Monday through Friday, normal daytime business hours, and realizing the patients don't always come in during those hours, but that person can then help navigate them to places where they can get follow-up care. So we'll do the induction, but then give them a prescription for some medication to tide them over until hopefully they can get into another place. And we have a number of places that we typically refer to that are close to our place. So that is, I think, the nuts and bolts. We're going to be looking at revising how we do the inpatient care as well. We have a really good addiction medicine physician at our facility, Dr. Shimin Nejad, who's brought a lot of, I think he's from the East Coast somewhere, and he's brought a lot of innovative ways of managing some of this patient population. So we've been working with him quite a bit to revise some of those pathways that we've got. Also collecting data and supporting some of the Medicaid quality incentive things like the naloxone distribution has been a big thing. We've been hitting the numbers. I think what we realized is that in looking at our data, we were doing a good job with the patients that come in with opioid use, but the Medicaid quality incentive is a little bit more broad. They want naloxone kits for more than just people that come in with opioid related drug addiction things. So looking at expanding that to increase anybody that comes in with some sort of substance use disorder. So that's the nuts and bolts, I think, of a lot of what we've done. I think I would just comment that I heard you talking about the MHA programs. I've worked with some of the MHA programs at the University of Washington. They do require you to have some sort of project identified with some things. So if you can have some of those things kind of wrapped up in a nice little package, there are definitely opportunities for those people to support. Obviously, you have to understand the types of people that you're going to get in those programs. A lot of them are just out of undergrad and very naive and don't have a lot of background. So you have to kind of,
Yes.
set your expectations accordingly. You're not going to get somebody that's going to just knock it out of the ballpark. I had a pretty good group of people this last semester. We worked on something related to pressure injuries because it was a very acute need that we had in our hospital, and got some decent stuff out of it. But
You could even
those
make
are-
it only available to the MHA
Yeah.
tour.
we had the EHA. I did the MHA program at the University of Washington. So that, and then we had students that were just the undergrad type. So I think different, you just have to have that
Yep.
in the back of your mind, knowing that, what
Yeah.
level of expertise or kind of skill you want to come in with. The EMHA program tends to have some nurses that have quite a bit of experience. So if there's things you're looking for, you can get some
Our
really good.
cohort was 70% physicians with 15 years experience.
Yep. You'll get some of those as well. So,
Real different.
but
Yeah.
they definitely, I know they're always asking for people in capstone ideas. So if there's people that, I can definitely connect to the people in the program, at least that
Yeah.
are there currently. So
It does sound like having some sort of package, and I think we have kind of started that with our, we have this matrix that's available for everyone, and we have we have a framework, so it's a kind of narrative discussion about the point of our guidelines and how we expect it to improve care across all of Washington state, and what kinds of questions we are interested in answering. I think that Sharissa, to your point, like one of the main things that we identified in this really is about getting people prescribed on MOUD and keeping them retained to treatment. So I think like the three kind of metrics that we identified, I think it was screening them for it, getting them engaged in care and on MOUD, and then retention to treatment were the three kind of focus metrics that we had for this guideline.
yeah, and we're really doing at Valley at least the first two pieces of that, and then trying to connect them in.
Yeah.
And then we just started looking at some rates related to kind of readmission type things, or patients that expire within 30 days of some sort of visit. Do we have an opportunity to intervene at some point? So we've
Gotcha.
been scanning through things like that with the medical examiner's office to get some records there to see if we could have prevented some of those events. But
So I think that you guys have all brought up some really interesting stuff. So one of the challenges that the Bree has is that we don't have access to overall data. And so Sharissa, I don't know if that is something that you and I could maybe talk about offline. You had mentioned that you guys, that maybe somebody is tracking that for OUD.
Yeah, I mean, I can, we have a dashboard that is updated periodically that's public. And then we just got from CMS some data looking at Medicaid files over a period of 5 years that looks at substance use disorder. So we're just going to validate that we agree with what CMS pulled. But then I think that's it's public information we get shown. It's de-identified. It's just big buckets.
Right.
So I mean, and we do have other things we could certainly share. Or I can connect you with our data team and see what, might be available there.
Okay. And would the HCA be able to make some of this data available if there was an organization who wanted help with an evaluation? Like if we were able to be like a matchmaker of sorts and say, here's this organization that wants help with an evaluation, here's a student, and you guys have the data, would we be able to get that from
I
you?
think so. I think I should probably connect you with Chris Chen if you don't know Chris, because we're
If you know
also
Chris.
launching a academic learning collaborative. And there'll be which is not exactly what you're talking about, but and we do offer some, I don't know what they're called, clerkships or internships with a number of, medical residents who've chosen. We've had a few MHA and maybe MPH students, but it's not broadly. We don't do as much as we used to. And I think that's because folks don't have time to precept really but I do think there would be interest in having that linkage to undergraduate or graduate students wanting to do a project, because the fewer resources we
and
have, the more help we need.
yeah, and Ryan and Amran, do you guys feel like that would be something that your organizations might utilize at some point?
Possibly. I mean, I think the one physician I mentioned, Dr. Nejad, he's got a lot of interest in this area. So, how to use that and utilize that. It's really difficult to see once patients leave our walls, what happens to them. So the
Right,
data
right.
information, we have a lot of data and information around the patients that come to us and what we do. And we can slice and dice that in a lot of different ways, but what happens to them outside of our walls is always the challenge.
Yeah, I think it would be helpful to also have that data set as well.
Okay. And Maureen, you had mentioned a lot of projects. So I think what the feeling that I'm getting is that there's like maybe a couple things that Bree could do, and one of them is this kind of big list of all of the efforts that are going on across the state. Would that be something that we would be interested in kind of collaborating with me on and talking, like kind of developing that?
I would love to. I already have a sort of mapped out where a lot of our projects are happening around the state, whether in the current and former projects, like the Health Point project is a health engagement hub. So I've mapped out, I have like my own Google map of everything that I know about going on. And I
Yeah.
love to understand this stuff, because I think one of the things that we want to be able to do as a team at Cedar, the clinical implementation side of things is really understand like where are things happening and where are there areas where more could be happening, because there seems to be there are opportunities for us to focus our attention in those areas for some training and technical support, or just figuring out like where we could be best used. So that kind of needs assessment evaluation is something that I'm really interested in and think would be very helpful for us and for other partners, I think.
Great. And then Drew, you had mentioned maybe partnering. Is that something that you might also, that the Alliance might also be interested in working on with us, is like some sort of big list, and then or needs assessment? I guess that's a good word for it, Maureen, I think. And then
Yeah, we'd be happy to, or at least I would be happy to contribute to the, looking at the list and seeing, where things are, maybe, where we can ask some other additional questions and, help to identify where we,
yeah.
I mean, there are lots of gaps, but where do we, go first? Sure.
Yeah. Great. Well, I really, really appreciate all of your guys' input. I think it's really helpful for me to hear from all of these different types of organizations about what their needs are, so that so that we could have a more complete picture of, what's going on, and then hopefully get some information about how our guidelines have impacted that in some way. I think these are all really great ideas. So I just wanted to close with some thoughts for you guys and give you an opportunity to chime in on anything else you might need. But I think that Sharissa and Maureen and Drew, I can reach out to you guys and we can start talking about maybe a couple meetings to flesh out how we might compile a needs assessment big list that the Bree can kind of host, or we can figure out how to combine it all, come up with a work plan for that maybe. And then I will go back to the foundation and chat some more about this idea that I've been having generally about having research capacity. And so Charissa, maybe I will reach out to you also about that. And Chris Chen as well. And then Ryan and Amran, we have tools available also where you can chat with other organizations, where you can get our help to kind of, I think you both brought up like what happens to patients once they leave your walls. And what the tools that I've created are really like wanting people to be able to use them so that organizations can ask kind of the same questions and know who's doing the work, so that you might call up or include another organization in your evaluation and say, we referred X number of patients to this place, and we know what happened to those patients, or however you would like to structure an evaluation if you have those questions. I think there are lots of resources, and so maybe I can set a meeting with the both of you and we can talk about those resources more in depth and see if they're useful to you, or what else might be helpful, to see if there's anything that could support evaluations in your organizations. Does that sound reasonable to you guys, or are there other things you need?
Absolutely. Yeah. Are there resources? Is there a website that I can look into just to see?
Yeah. I will drop it here.
Thank you.
Yes, and we have 5 minutes left, so why don't I just share it with you guys all visually? You can see what we got going on, and then it'll be a little more clear. All right. Can you see my screen there?
Yeah.
Yeah. So this is our Bree Collaborative website, and I'll drop the link in the chat. So we have this section right here. This is our implementation guide. So basically anything you want to know about any topic that we have, it's all in here, and you just click on whatever category you would like. If you click over here, it takes you directly to the report. But so, for example, and I'll just pull up this OUD, so it's under behavioral health. You can see all what's under there. So when you click on it, you'll know. And that's this one here. And then you just scroll down to the section that you want. Sorry if this makes you dizzy, but it's at the bottom. There it is. So we have our guideline. You can read it online. We have checklists for implementation, lots of different resources, all of our webinars. These are the specific tools that I was talking about. So we have this evaluation matrix, and it kind of outlines like whatever the component was of the guideline. So say education, and what the recommendations were and what kind of audiences those recommendations were aimed at. And then how do we think you should measure that? So there's some recommended metric. And it's worth kind of looking at. We have this framework, which is the narrative section. So it goes into, it talks about like, we think that these are measures that you should use. These are measure concepts that you should use. We think that these are questions that should be answered. It's a very long document. It's worth a dig into. We had a subcommittee that put this together. And then we have a few, like we have like a collect your data template for your evaluation. And then we also have this theory of change, which kind of gives you a broad picture of how we think our recommendation should impact the system. For each, and I think this one is set up as like at the state level, at the organizational level, and at the community level. And it can just help you like find where you are in that map, basically. And then the last thing we have are these scorecards. And so these scorecards are where you can look to see how an organization is aligned with the recommendations of the report. And usually what our smaller organizations have done, actually even the Department of Health has done this, they look at their scorecard, they pick one thing to work on and to evaluate. So for example, in our infection prevention, when the Department of Health picked communication with the public to spread, or communication with providers to spread best practices about infection prevention, and they developed a playbook for new infection preventionists in an outpatient setting. It's just one guideline from the Bree. But these are very helpful. Other organizations have used them to kind of plan what they're going to implement and plan how they might measure it. So those are all available as well. Oh, and if you click on it, it downloads. And then this is a new thing that I have just set up, which is a message board. So for example, if two organizations are working on it, or you just want to get an idea, does anybody have a survey about this, or is anybody else working on this? There's this message board. These are brand new. They don't have anything in them yet. We were just set up today. But you click on it and it takes you to our member league message board. Bree can answer questions that you have, or other people can answer questions. So there's, lots of collaborative ways to work together. And then we also have this site here, which has all of our other types of evaluation tools. So these are more generic. This is just a large survey bank that you can access, a large tool depot if you're looking for a good logic model or anything like that. And then there's some other things in there. I'll just jump to it. So there's action and logic models, theories of change. This is really geared toward those organizations that may not have a lot of evaluation resources and need some more, and can't really pay for them because they're all free. So, and we even have some software, some EpiInfo, and some other things that are available. So it's just kind of a one-stop shop, all in one place. You don't have to go searching around for all this stuff. So that's what we have on our website so far. I would be happy to chat with you guys and figure out what else we can do to make it more useful, and also to maybe stand up some of these other things that we have talked about, like a needs assessment, a large list of places that are already doing the work.
Happy to connect. I have to jump off because I've got another
Yep.
meeting, but
It's 1 o'clock
you.
now. So
Yep.
I'm just going to drop this in the chat too, and then I will send it out to you guys also. So thank you all very, very much for attending and for staying just a few minutes longer here. There is the link to our implementation. Oh, nope, that is not the link. Let me try that again.
You can just email it.
Yeah, I will do that as well. Yeah. Great. So I have some follow-up, and I will be reaching out to you guys either this week or next week with those follow-ups.
Thank you so much. Take care.
Thank you again. Bye-bye.